Hello, and welcome to today's webcast, EEG Changes Associated with COVID-19. My name is Marie Baldessari, and I will be moderating today's webcast. My background is that I am a professor of critical care and neurocritical care at the University of Pittsburgh Medical Center. I co-direct the neurovascular ICU, and I have nothing to disclose. I'm sharing today's webcast with my co-moderator, Javier Provencio. Javier, can you tell us a few words about yourself and your disclosures?
So I'm Javier Provencio, and I am the medical director of the Neuro ICU at the University of Virginia and a professor there as well as a researcher. I am a consultant for Minitronics and a medical advisor for LifeNet. And I do get grant support for a couple of things that I don't think are directly related to this, but may be tangentially related to this. So I wanted to let you know that.
Thank you, Javier. So please note that the webcast today is being recorded. This recording will be available to you within 1 to 2 days. You can either access it at the SCCM website listed here or the Neurocritical Care website, also listed here. The disclaimer for today is that all of the content provided by the speakers and the moderators is intended only to provide information and for educational purposes only. For audience participation, you can submit your questions through the question box, which you see listed here. And this is located on your control panel. We're very excited because this is the first partnership in terms of webinars between the Society of Critical Care Medicine and the Neurocritical Care Society. We hope it's one of many that will come in the future. I'd like to say thank you to our sponsor, Ceribell. To learn more about the rapid response EEG from Ceribell and how they can help minimize your staff's exposure during COVID-19, please visit them at the website. Our sponsor's website information will also be available to you in the chat box and will be sent to you 1 hour after this webcast. And now I'm honored to introduce our 2 speakers today. First speaker is Dr. Sahar Zaffar. Dr. Zaffar is a neurointensivist and clinical neurophysiologist and assistant professor of neurology at the Harvard Medical School. She practices at Mass General Hospital. She has a particular her research interests focus on EEG monitoring in the ICU, as well as anti-seizure medications, looking at efficacy and effectiveness in the acutely ill. Dr. Zaffar has nothing to disclose. Our second speaker is Ms. Elizabeth Zink. Ms. Zink has been a clinical nurse specialist. She has been a nurse practitioner, a staff nurse for more than 23 years. She's presently working at the Johns Hopkins Hospital in the Neurosciences Critical Care Unit. She has published and lectured nationally and internationally in the fields of neuroscience critical care. And Ms. Zink has nothing to disclose. All right, I think we will begin with Dr. Zaffar, who will do the first presentation.
Thank you. I'm excited to be doing this, and thank you for all those who are attending. So I will be talking about the indications for continuous EEG monitoring in patients with COVID-19, the common abnormalities we see in these patients, as well as their relation to outcome, and sort of looking at the general impact of COVID on EEG utilization. I think before I start, it's, the one thing to sort of take into account is the rapidly changing face of the pandemic and what we're learning about the disease itself and neurologic manifestations. And so a lot of the data that I will be reviewing, of course, comes from either case reports or small case series, and we're slowly accumulating data to help answer some of the questions that we will be addressing in this presentation. So first, to talk a little bit about the impact the pandemic has had on continuous EEG utilization. To address this, we actually conducted a national survey to determine how the pandemic has impacted continuous EEG or CEEG volume, utilization, and the health impact it has had. And of the 79 centers that responded to our survey, about 70% majority reported that they have had a reduction in the CEG utilization. And then they noted, what we found was that the reduction was similar across all centers, across all regions of the US, as well as within centers that were within, as well as outside of COVID-19 hotspots. So taking a deeper look into the survey itself, we found that there was a reduction in continuous EEG utilization across both teaching as well as non-teaching hospitals, across small as well as large cities. But what we found was that there was the most notable reduction was reported in the Northeast. And this, maybe because the surge of the pandemic and the highest number of cases were seen earliest in the Northeast compared to other regions of the US. This survey was the period over which this survey was conducted was the last 2 weeks of June 2020. Similarly, we found, as I had mentioned before, that a reduction was reported not only within COVID-19 hotspots, these were self-reported COVID-19 hotspots where there was rapid accumulation of cases, but also outside of hotspots. And what we found also was that centers that had reported the highest reduction in transfers from outside hospital also had a reduction in CEG volume as well as utilization. And then finally, centers that reported a reduction in their EEG technologist staffing reported a greater reduction in continuous EEG utilization. Other things we found in our survey was that about 30% reported a reduction in EEG technologist coverage. A small percentage of centers did report PPE or personal protective equipment shortages, specifically for EEG technologists. And interestingly, we found that a very small number of centers increased or started to use tele-EEG or rapid response EEG application systems such as the Ceribell system. And we'll talk a little bit more about this towards the end of the talk as we brainstorm ways to improve EEG utilization during the pandemic. So coming back to the main indications, again, this is data collected from case series, case reports. We've recently conducted a multi-center study as well. And by far the most common indications for continuous EEG utilization in COVID-19 patients is encephalopathy or altered mental status and coma. And the reason for EEG monitoring in the majority of these patients is to rule out non-convulsive seizures or electrographic seizures. Second, paroxysmal events, and these include events such as abnormal motor movements, myoclonic jerks, gaze deviations, or sometimes even paroxysmal autonomic phenomenon. This is another common indication for getting continuous EEG in COVID-19 patients. Less common indications include monitoring the depth of sedation, particularly in the severe ARDS patients who are undergoing ARDS mechanical ventilation. And then finally, less often also prognostication or neurologic prognostication, which is a less commonly reported indication for continuous EEG monitoring in these patients. When it comes to findings, again, just to highlight that this is data that is continuing to grow, and we're continuously learning more with the rapidly changing face of COVID. But across all the studies that have, the case reports or case series that have been reported so far, including our study, which was a multi-center study looking at 197 patients, the most common EEG finding across all these studies and in a majority of COVID-19 patients who undergo EEG is just generalized slowing and disorganization of the background. So that's loss of the normal background that we see on EEG monitoring, as well as diffuse slowing. And this generally tends to be seen in patients who have global dysfunction resulting from metabolic derangements, resulting from hypoxia or anoxia. We know this from in general studying EEG in critical care setting, and that is what we assume these changes are caused by in COVID-19 patients as well. Next, sporadic epileptiform discharges. So these are disorganized, sharp, or epileptiform waves that are seen in no particular pattern. These are the next most commonly found EEG finding after just generalized slowing and disorganized background. And again, if they're diffuse, they can be a marker of a more global neurologic dysfunction resulting from metabolic derangements or hypoxia. If they're seen more focal or in a specific part of the brain, one would expect or can expect that there may be an underlying acute CNS lesion in that part of the brain, or even an old or a chronic injury in that part of the brain. Periodic and rhythmic patterns, which we are now recognizing more and more in critically ill patients that undergo continuous EEG monitoring, have been reported in up to 20% of COVID-19 patients that undergo EEG monitoring. And even again, within the periodic patterns themselves, generalized periodic discharges are the most commonly seen. And again, generalized periodic discharges, also known as GPDs, tend to be a marker of a more global or more diffuse pathologic process, as seen in patients with metabolic derangements, uremia, sepsis patients, patients with anoxic or hypoxic brain injury. Those are the scenarios where we see these patterns more often in. Lateralized patterns, such as lateralized periodic discharges and lateralized rhythmic delta activity, these are seen less often or have been reported less often in COVID-19 patients. And when seen, they tend to be seen more often in combination with an acute or even a chronic focal or structural brain lesion, such as an acute stroke or even an old stroke or old TBI. Although we can at times see these with diffuse metabolic derangements as well. And then finally, electrographic seizures. These are the least commonly reported. The highest reports have been up to about 10% of patients undergoing continuous EEG monitoring. And electrographic seizures in COVID-19 patients seem to be more often in combination in patients who are presenting with clinical seizures, or patients that have an older chronic brain injury, such as an old stroke or old TBI. So in general, all these findings, epileptiform discharges, periodic and rhythmic patterns, as well as electrographic seizures across all studies tend to be seen more often in patients who are presenting with clinical seizures or in patients who do have a known or a structural brain injury. About up to 20% of the patients that had these findings were reported to have an acute structural brain injury, such as a stroke or a hemorrhage. And there have been very few reports of COVID-19 related meningitis or encephalitis itself resulting in seizures. So for the most part, and I'll go a little bit more into risk factors, it appears that these epileptiform patterns or electrographic seizures tend to be seen more often because of the metabolic derangements or due to older brain injury, and not because of direct invasion by the virus. But again, this is what we're finding so far, and as we look more into this, that data may change in the future. So going through just a few examples, this is the first example of an 89-year-old female who has a history of chronic kidney disease, hypertension, and a remote non-small cell lung cancer, who presented with fatigue and superimposed bacterial pneumonia and had a COVID-19. EEG in this patient was performed for a delirium workup and to rule out non-convulsive or electrographic seizures. The patient did have a CT head, which showed no acute pathology, no acute structural lesion, and her EEG essentially showed generalized slowing, which I mentioned was the most common reported finding in these patients. So if you look at this, for those who are not familiar, this is the left temporal chain, looking at the left part of the brain, the right temporal chain, the left central area, the right central area, and this is the midline chain. And again, what we see is there's lack of any organization, and there seems to be generalized slowing. And again, this seems to be seen most commonly in association with a diffuse process, such as metabolic derangements, uremia that is often seen in these patients, and can also be seen in the setting of sedation. So one important thing as we talk about approach to monitoring these patients, when we do start EEG monitoring, paying attention to the amount of sedation that they're actively on, or this sedation that they've received in the past, is important to take into consideration as we interpret EEG in these patients. Often due to their kidney injury and liver injury, they clear sedatives very slowly. So even though they may have been off of sedatives for a while, the EEG may still show generalized slowing due to the retained effects of the sedatives that they have been on. Next is an example of a 65-year-old female patient with chronic obstructive pulmonary disease and HIV, who presented with shortness of breath, chest pain, and cough, and was admitted for COVID-19 pneumonia, and again underwent EEG monitoring for an indication of encephalopathy. And her EEG, similar to the prior EEG that I showed you, was that there was generalized slowing, there was lack of organization or the normal background that we see, and on top of that, we see these what look like sharp or epileptiform discharges that tend to have a more sort of diffuse presence. And again, this is an example of patient with sporadic discharges. This patient also did not have an acute structural brain injury, but did have significant metabolic derangements, including uremia and a significant AKI, and we suspect that these findings were seen in relation to the metabolic derangements. The next example is of a 68-year-old male patient with hypothyroidism who had a deep venous sinus thrombosis in the past, currently not on any anticoagulation, who presented with altered mental status, respiratory symptoms, and also a fall, and was admitted and diagnosed with COVID pneumonia. And he underwent EEG monitoring, again with the indication for encephalopathy. In this patient, we did also find the CT head did show an acute on chronic subdural hematoma and did not go any operative management. And with regards to labs, they were again found to have diffuse metabolic derangements, including hypernatremia as well as uremia. And here what we see is generalized periodic discharges, again on a background of diffuse slowing, lack of organization. We see these sharp waves that, if you pay attention, are occurring periodically at about 1 per second. And these are called generalized periodic discharges. Again, the clinical significance of these discharges, they're typically seen in patients with a global or a diffuse process, such as in our patient uremia. Anoxia can also result in generalized periodic discharges. They can be seen in association with a focal or a structural brain injury as well, but more often are seen with a more diffuse process. And finally, the next example is of a patient who also was admitted with COVID pneumonia. They had a history of a frontal stroke, and they underwent EEG monitoring because of episodes of shaking or paroxysmal episodes of abnormal motor jerking movements and encephalopathy. And in this patient, they were found to have electrographic or seizures on their EEG monitoring. I don't have the site of onset in this, but they seemed to be arising from the old left frontal stroke that this patient had, or that was the site of onset. So again, here's an example of a patient with COVID-19 who did have electrographic seizures that seemed to be emanating from an old brain injury, likely in the context of them being acutely ill with all the superimposed metabolic derangements that they had. So just to summarize again, we talked a lot about the various risk factors, but in general, across most studies and most reports, it's been seen that EEG abnormalities, including epileptiform discharges, electrographic seizures, tend to be seen more often in patients who are coming in or present with a clinical seizure, those who have a history or old intracranial lesions. In our cohort, about 60% of patients with electrographic seizures presented with a clinical seizure, and 70% of patients who did have electrographic seizures had a history of an old brain injury. Acute structural brain injuries, such as acute strokes or acute ischemia, have been reported in up to 20% of patients with abnormal EEG findings across all the studies that we've seen. And then again, as I mentioned, reports of actual COVID-related meningitis and encephalitis resulting in seizures, although reported, it's so far been primarily in case reports or a small a number of patients that have had seizures resulting from a documented meningitis related to COVID-19. Other risk factors, so across several of the studies, elevated inflammatory markers, and particularly elevated C-reactive protein, and as well as elevated D-dimer have been found to be associated with both epileptiform abnormalities as well as seizures, and transaminitis, specifically elevated ALT and elevated AST, have been shown to be associated with a higher risk for electrographic seizures, as well as other epileptiform abnormalities. And then finally, this is preliminary data, but looking a little bit into what is the clinical or the prognostic significance of these findings. In our study, we did find that patients that had electrographic seizures or had a higher hazards or more likely to have inpatient or in-hospital mortality. And then patients who had non-convulsive seizures or epileptiform abnormalities did have a longer length of hospital stay as compared to patients who did not have any epileptiform abnormalities. So again, but this is again coming from a small cohort of patients. This needs to be replicated in larger patient populations. Looking back at critically ill patients in general, however, and all the work that has been done on looking at the significance and prognostic significance of EEG, these findings are similar to that seen in other critically ill patients, where presence of seizures, presence of epileptiform abnormalities, presence of periodic discharges do tend to be associated with worse discharge outcomes, as well as worse long-term functional and cognitive outcomes. So then to summarize, amongst patients who do undergo continuous EEG monitoring, COVID-19 patients who undergo continuous EEG monitoring, EEG abnormalities are frequently encountered. And so we should be considering monitoring in higher risk patients. And who are the high risk patients? Those who are presenting with clinical seizures, those who have a history of structural brain injury or known history of epilepsy, those who have an acute structural brain injury, and consider monitoring in patients who are encephalopathic or mental status is out of proportion for what you would expect for their level of sedation and have significant inflammatory marker elevation, particularly CRP and D-dimer elevations. The next talk will focus more about on EEG protocols and performing actual EEG, but given the length of the pandemic and the anticipated frequency in surges and what we know from our survey on how the pandemic has impacted EEG, we need to start thinking of ways to optimize or improve continuous EEG monitoring in these patients, particularly in light of the frequency of these abnormalities. And so areas where we could improve or enhance our services would be including tele-EEG services, and then also the role of rapid EEG application systems such as Ceribell, which is an 8-channel EEG application system that can be used in the absence of or when there's shortage of EEG technologists or actual EEG equipment to be able to perform EEG in these patients. And so with that, that's the end of my talk. Thank you. And I'll take questions at the end of this session.
Thank you, Dr. Zaffar. That was a wonderful review of what's been happening with EEG seizures and our COVID patients. And I think we'll have Ms. Elizabeth Zink now follow up with how do you implement a continuous EEG program in your COVID patients with all the problems that we're being faced with technology and personnel and PPE. So if Elizabeth could take it away. Thank you.
Thank you so much, Dr. Baldessari, and it's my pleasure to be with you this afternoon. So I will be talking about the practical considerations of, or how do we do it. So we'll go ahead and get started. So we'll discuss the differences in applying continuous EEG with and without COVID, before and after or during COVID-19. We'll discuss recommendations and implementation of continuous EEG based on recent published experience and research, and identify safety strategies. So I do want to disclose my background is nursing. I'm not an EEG technologist, although we are collaborating with our EEG service quite a bit. And so I wanted to share our experience and hopefully troubleshoot any issues that you've been having in that collaboration. And so I want to start with building on existing critical care EEG programs. I think one of the early issues was that our emergency planning committees and our organizations really thought of this primarily as a pulmonary disease. And I think that because of that, we concentrated on making sure we had enough ventilators for good reason, and making sure we had critical care staff and respiratory therapists. And there wasn't a spotlight on EEG. And then when we got into the pandemic and really started taking care of these patients and really realized what a systemic process COVID-19 was causing, we started to realize the need for EEG and for other services. And so I think there isn't a magic necessarily, but a lot comes down to communication and advocacy in terms of leaders in critical care, particularly in the neurosciences, making sure that they're at the table and advocating that for the EEG service. I think Dr. Zaffar mentioned PPE shortages. And again, I think as our emergency planning committees were allocating PPE, again, they didn't think of ancillary services right away, and in particular EEG. So I think as much as we can, as critical care leaders, advocate in our own facilities for these other services, and in particular EEG, that will be needed, we need to bring that to the forefront and educate our other colleagues that are trying to do the best they can, but clearly can't think of everything. And so we really want to build on our existing critical care programs. And if you were doing a lot of continuous EEG in your critical care units, then really collaborating, this is an opportunity for collaboration for nurses to collaborate with the technologists as they come to hook up. As you know, these were very complex patients with a lot of equipment, and being shut in that room to then apply the EEG, it can be quite intimidating. So, so we saw this as an opportunity for collaboration, a willingness to assist in positioning the patient to apply EEG. The other point of communication is really making sure the team is aware, everyone on the team is aware of the indication for the EEG. There's nothing worse than having someone, a technologist, come to the bedside to do the test, and someone says, well, we're not really sure why they ordered this in the first place. So really, and in somebody who is hesitant in the first place, this can be a problem, but it's something that also is easily solved in trying to enhance the communication there and make sure everyone is very clear on the goals of the day. So infection control practices. So as everyone knows, we're using airborne precautions in these patients in most areas. And so that consisted of PAPRs or an N95 mask with shield. And again, this is an opportunity for communication and making sure that our ancillary services are availed of all of the information that's coming from emergency preparedness centers within the organization, making sure that they are availed of the training resources. So again, I think as leaders in critical care, we can make sure that they are included. And the donning and doffing of personal protective equipment really is a little bit different than we're used to. In some cases, I know we had a different procedure for COVID-19 patients than we had prior. And so it is completely doable, but it does take training. There are job aids. And by different, I mean that we were using 2 pairs of gloves, and there's a certain order that we put those gloves on, cleaning hands at different points during the procedure. So it was a little bit different, but again, is easy to do with training. In talking to the EEG service, they really, to the technologists, they really thought about what they needed to bring with them into the room prior to going. And so we used disposable electrodes. They usually had a tackle box, so they would take supplies for several patients with them. But during this time, or going to units with patients with COVID-19, they would take just what they needed. Again, for the prep materials, gels and pastes, they would aliquot those into individual containers. And device decontamination, again, I'm fairly vague on approved disinfectants because we are changing according to what is available on the market. So an approved disinfectant for the machine and what is available should be used to cleanse the machine. And it was recommended, it's been recommended by a local neighboring institution that we sequester the device for 24 hours. That was not always possible for us. So if that was not possible, then a second cleaning is recommended. So other considerations include leads, and I think here this really is dependent on the clinical question. So if the clinical question is one that is immediate, is the patient having electrographic seizures or not, and the monitoring is thought to be short-term, then technologies such as the Ceribell could be very useful in answering that question. It's also been suggested that needle electrodes be used. It does take someone who is very familiar with this application process. And again, this is for an emergency application that is then removed, as you know. So that is possible. In all other circumstances, cup electrodes are sufficient. There was some talk in different institutions of using a limited array versus a full array, and again, it would depend on the clinical question and the detail that you're expecting to get. And again, if the Ceribell could come into great usefulness here again, if in an emergency situation or a situation where much of the equipment is already in use and you need to answer the question of electrographic seizures or no, that could be very useful again. So adhesives, we are primarily a gel and paste institution, except in our epilepsy monitoring unit for long-term use, collodion would be used. And as you know, there is an aerosol pump that's used to dry that adhesive. And so that is not recommended during this time. So anything that would cause an aerosol is not recommended. And in the let's see, lead refreshing considerations. So for patients that are receiving continuous EEG, the technologists would monitor remotely, or the epileptologists would monitor. And if leads are coming off, they could potentially go to a unit several times a day to re-affix those leads. During this time, it was a frank discussion as to what information was missing and how urgent it was to refresh those leads. So they really tried to keep the refreshing to once a day, once every 24 hours. And if they could wait to replace the lead, then they would. Again, to minimize exposure and also minimize PPE use. Patient positioning, so patients can be monitored when they're in the prone position, and so many of these patients require that. So there are, of course, we do worry about skin breakdown. These patients have other reasons or risk factors for skin breakdown, but we can mitigate this with positioning aids. at the head. There are donut pillows that can offload pressure directly on the leads, and there are other pressure offloading devices that can be used. And many times those devices are already in use because the patient is in the prone position. So you can be creative in making sure that these positioners are around the leads so that we can prevent skin breakdown as much as possible. Video EEG in guidelines was suggested if that is possible. So the interpreter of the EEG knows the patient's position and can interpret appropriately. So staffing, we talked a little bit about staffing. So redeployment of staff during this, during the period of surges, we had a reduction in, or actually a cessation of outpatient and elective cases. So patients in the epilepsy monitoring unit were not coming in, and we didn't have normal outpatient appointments. So that staff could potentially be redeployed. Trainees could potentially be a source of personnel to cover this if properly trained. What the technologists did experience is that there was an increase in time associated with applying the EEG, and they estimated this to be about 45 minutes. They were able to offset this again with the increase in staff. And again, collaborating with nursing staff so that if they needed an extra pair of hands for positioning, that was available. So in summary, building on existing relationships, communicating, making sure that EEG services are included in emergency planning for any surges that are occurring now and in the future is critical. And then continually assessing our processes for the need to adapt and change. We are lucky that many of the clinical neurophysiology societies did put out guidelines that were very helpful to technologists as well, and some of those are in the references. I would like to acknowledge our clinical EEG laboratory and service and the chief technician, Lauren Cobb, who was very helpful in helping me to develop this presentation. So with that, I will turn it over to Dr. Baldessari and Provencio.
All right. Thank you, Elizabeth. That was a wonderful talk. Since you spoke last, I would like to ask you one question about staffing. I do know that you remember in the beginning, you know, there was quite a bit of fear about fomite contamination and surfaces. And I'm just wondering, how did that affect your staff? Was there a great deal of reticence about going into the patient's room, or was there a lot of absenteeism because of fear, or even childcare issues, or concomitant illness?
Yeah, so that's a great question. And I did talk with our lead technician about that, and we are incredibly lucky that her response was patients needed our help and we went. And so I think we have champions in EEG here, and so that helped. But I do understand those concerns and those staffing concerns that occurred across different specialties. I think communication is really a key. Some of these ancillary services that are not directly tied in with units, I really feel like that's something that needs to be remedied. And I think that only worsens that concern about going into rooms. Well, they didn't even provide us with personal protective equipment. I think communication, again, is so important.
Javier, did you want to ask any questions?
Yeah, so Sahar, there were some questions that were relayed from some of the listeners, as well as some pre-questions that have to do with the fact that a lot of these patients with COVID end up getting a lot of sedation in order to keep their respiratory status intact. And the questions arise around, can you tell the difference between sedation-induced mental status changes by EEG compared to primary brain injuries? And how would you do that? What specific findings would you expect?
Yeah, no, that's a great question, and that's a little bit hard. I think, you know, when you see you know, sedation-induced slowing, there are certain features in slowing that could point towards sedation. So specifically, for instance, if the patient's on a lot of propofol or midazolam, one, if you see a burst suppression pattern in association with that, you know that that's, you know, related to sedation. If they obviously are not getting enough sedation to burst suppress them, often if they have diffuse slowing, and we specific things that are seen in relation with sedation, such as benzos or propofol, is it superimposed faster frequencies. So, you know, if it's sedation or medication related, we see the slowing, we see superimposed faster frequencies. It's generally symmetric and diffuse. If we're concerned about an underlying brain pathology, you know, the slowing, maybe you may see focal slowing, more asymmetric slowing that points towards an underlying brain pathology, slowing along with presence of periodic patterns or epileptiform patterns or seizures, of course, but even just sporadic discharges or periodic patterns point more towards another pathologic process. Sedation wouldn't, you know, produce any of those patterns. So, you know, if you just see symmetric diffuse slowing with some superimposed faster frequencies, I would think this is slightly more related to sedation. But if I start to see any asymmetry or any superimposed pathologic patterns, and I would think, you know, dig deeper into why that is happening.
You know, and a related question is, for the non-seizure associated EEG findings, so if you don't have frank seizures, at what point do you bite the bullet and start patients on anti-epileptic medications, especially given the fact that EEG abnormalities have a worse prognosis in COVID?
Yeah, again, great question. And I think, you know, while seizures or discrete seizures, they're easy to target or treat, these findings that, you know, are not clearly seizures but are not benign interictal discharges are coming to be known as the ictal interictal continuum in critically ill patients. So it's a challenge in general, not just for COVID, but in general critical care as well when we see these findings. And while there's guidelines on how to treat seizures or status, there's no clear-cut guidelines on managing these patients. But I think we're learning more and more on how to combine the clinical context with the EEG findings in order to prescribe anti-seizure medications. And so one approach is, you know, if someone has, you know, is encephalopathic and you're seeing lateralized periodic discharges or, you know, lateralized findings that often point more towards a focal process, and they have a clear clinical correlate, then, you know, we would tend towards treating that patient. So an example being, if someone, you know, you're concerned that they're very encephalopathic, and you get an MRI or a CT scan which shows an old stroke or maybe even acute lesion, and you get EEG which shows these periodic patterns, and, you know, their exam is out of proportion for what you would expect their imaging to show, then I'd lean towards treating those patients. Someone who is encephalopathic and you get EEG and you see generalized periodic discharges that you know are often seen in relation to metabolic derangements, and they're clearly uremic, it's reasonable to, you know, try and fix their uremia, give them a little bit time to see if their mental status improves as their metabolic derangement improves, and before starting AEDs. So that's sort of one approach. And another guiding approach is there's data out now that shows that these patterns that are not clearly ictal, but if they are high frequency, so if they're, you know, 1.5 hertz or faster on the EEG, or if they're high burden, that is, they're occupying more than 50% of your recording, those patterns, high frequency and high burden, are more likely to be associated with clinical or electrographic seizures. And so if you're seeing patterns like that, then you can consider doing an AED or a seizure treatment trial in those patients.
Dr. Zaffar, let me flip the coin here and say, I know this is all about EEG monitoring, but what about those folks that don't have EEG monitoring, or the EEG tech can't get in that day, and you have a patient with neurologic symptoms? One of the questions asked by Stuart Stein was, given the poor prognosis with seizures and COVID, Should we start these patients empirically on anti-epileptics?
No, that's a great question. And I think, you know, the challenge here is that AEDs themselves or anti-seizure drugs themselves are also not benign. And especially in COVID-19 patients who we know have hepatic, you know, abnormalities and have acute kidney injury, AED clearance in those patients will be significantly impacted as well. And so, you know, I think if you have a patient where you're concerned or suspecting seizures and they're just encephalopathic and EEG is not immediately available, you know, options would be try and consider, you know, a rapid EEG application system that could give you, you know, some idea of, you know, not as detailed, but at least some picture of their brain. Or if continuous EEG is not available, even a routine EEG. And then I guess if you have a patient who comes in with you know, a known history of seizures or who presented with seizures, or a patient who comes in as encephalopathic and you see that they have a, you know, a stroke or a hemorrhage, you know, just, you know, I'd use, instead of just saying the patient has COVID and they're encephalopathic, let's empirically treat them, I think you would require a little bit more evidence than that. And so either, you know, paroxysmal events or head imaging that has a large stroke or temporal intraparenchymal hemorrhage or an injury in one of the more epileptogenic areas of the brain. In those patients, you could consider empiric treatment, but I think because although we know seizures are bad and they seem to be associated with worse outcome, we don't really know whether treatment actually improves outcomes. So it's hard to, you know, definitively say, yes, let's empirically treat all these patients because we don't have that data. So I think it just has to be case by case and trying to combine all the data, the big picture, putting all of that together to treat these patients.
So Elizabeth, if I can sort of jump in with a question too. I know there's been a big push with COVID patients to try to keep people out of the room and to do things like moving IVs outside of rooms in order to manage them out there, and ventilators as well. With EEG, that's a little bit harder because most of the standard EEG setups also have a camera. And one of the questions that came up was, how important is the camera in all this, or do you advocate just moving the EEG machine outside the room so that you can actually have access to the screen, even at the expense of the camera?
That's a great question. And when I was reading published experience, there was some report of using an extension type cable on the jack box to be able to extend the machine out into the hallway. There really is not a good answer. I would say if you have the option to telemeter the data to another location, then you could leave the machine in the room. Absolutely. There are some of the larger societies seem to advocate for using the video if you had it, so that the interpreter could see the patient position and could use that for interpretation. So I think those are some of the factors to consider. So I think if you don't have that option to telemeter the results, then maybe having the machine outside of the room is a good idea.
And sort of as a note, one of the technical issues that many people don't know is that the EEG signal is extremely amplified compared to an EKG. So there's actually an amplifier box that has to be relatively close to the head, but you get signal dropout the longer you go. So moving it further away can actually be technically problematic for doing the actual exam. So you have to consider that, because I know the push is to pull everything outside the room. I think the cameras can be beneficial, but I also think that you may run out of EEG signal. Another question from Keller actually is the idea of using sub-scalp electrodes or invasive electrodes compared to traditional CEEG, continuous EEG. Do either of you have experience with those?
I do not.
Yeah, we haven't, at our center, we've been using one-time application electrodes as well, although there is data that shows that those subdermal electrodes can be safer, or, you know, but I don't think there's a lot of centers using those during this time. I think if anything, centers are looking at using rapid application systems in lieu of the full scalp electrode montage.
Dr. Zaffar, in my review of the literature, I guess I was a little bit surprised, and you covered this very well about the mechanism of seizures, that we feel that the majority of them are secondary to hypoxia, metabolic, electrolyte abnormalities, but considering how the virus invades through the olfactory bulb, sort of directly into the brain, it's surprising to me that we don't have more evidence of neuroinvasion or neurotropism. Can you address that?
Yeah, I think that's a great point, and I think part of the challenge here is that we're just learning about all of this. Mm-hmm. And I think, if you look at the earlier studies that were done, that even came out of China, for instance, where they talk about neurologic manifestations, they actually didn't do EEGs. A lot of the earlier studies were done at centers where EEG was just not being done because of the fear of, the health risks and the health impacts. And so it's only later on and more recently that as we start to use EEG more in these patients, that we're starting to see these results. And so I think, so the few studies that have looked at CSF findings, for instance, in these patients, again, it's not all these patients end up getting LPs. And so when patients do get LPs, about half of them do have CSF abnormalities, either elevated white count or elevated protein in the CSF. But the denominator is so small to begin with, the total number of patients that are actually getting this, that it's hard to draw any conclusions. I think that as we learn more, and as I know that the Neurocritical Care Society, for instance, there's an entire group now working towards, studying the neurologic impact and sequelae from COVID-19. I would not be surprised that we learn more about, the actual direct impact of the virus on the brain and resulting in some of the findings that we're seeing. I think it's just the quality of data that we have so far that is one of the limiting factors.
And I will tell you, the interest about neurotropisms with this virus have a lot to do with early studies that were done in animals in the early 2000s with SARS, the original SARS virus, that found that there was neurotropism, but very specifically for the brainstem, not for the cortical. And the CSF abnormalities, at least in these animals, were not common. So we don't have very much data in humans. SARS was such a limited infection. But that at least in these animal studies, we don't expect to see a lot of cortical stuff if SARS and SARS-CoV-2 are similar in the neurotropism part. So I'm not sure it would lead to a lot of seizures or encephalopathy, maybe encephalopathy, maybe not a lot of seizures.
Another presumption I had when I started reading the literature was that most of the patients who had seizures associated with COVID would be the far sicker patients, the bad ARDS patients. But as you know, there was a study by Mao in JAMA Neurology that showed, in fact, most of the seizures happen in the less severe patients. And I had a little trouble understanding that. And any thoughts?
I think one of another study also found that most of the actual electrographic seizures happen in patients who presented with clinical seizures. And a good number of these patients also have a history of epilepsy. So I think part of it is also, if someone, and again, I don't understand why they did not get sicker, but, patients with epilepsy, any infection, can lower their seizure threshold and result in seizures. So, there's so many, patients with epilepsy who are coming in with seizures like this. Maybe they were younger than, the older patients that have, or they did not have all the other comorbidities that we're seeing with the patients that tend to get sicker. So I think, again, it's just a matter of numbers, because we have such a small N that is giving us all this data. It's hard to, draw any definitive conclusion. But that's one of the things that I'm thinking is that there's, some of these patients are epilepsy patients. They're younger, have no other comorbidity, and are just, have seizures because they have an infection. That's one hypothesis.
Okay, now I want to throw out a question to both of you that hasn't been asked, but I think is important. Because everybody, we now have at least a clear idea of who should get an EEG, and especially who get continuous EEG monitoring. The real question comes up 2 days later with, when do we stop? And I'd be interested to hear both of your input about how long should we monitor these people?
Right.
Yeah, so I mean, I can take it on, and then Elizabeth, I'll open it up
Sure.
to you. So I think, you know, I would again sort of, because our knowledge for COVID-19 patients themselves is, you know, limited to sort of the data we have, I would sort of extrapolate from what we know of the general critical care population and EEG monitoring in them. And what we found is that even in general critical care, if you start someone on continuous EEG monitoring and you see that their EEG is abnormal, they have epileptiform abnormalities, or they have periodic discharges, and definitely if they have seizures, you want to continue to monitor them for at least 24 hours. But the longer the yield of EEG, especially if you connect EEG and there's nothing abnormal, or it's just generalized slowing, and it stays like that for hours, the yield of finding something abnormal continues to decrease with time. So what we found is that if you monitor someone for, you know, 6 hours and you found nothing, then the likelihood of finding something beyond that point, you know, starts to drop, and it drops significantly at this cutoff of, based on a large study, at about 16 hours, that if you've gone up to 16 hours and haven't found anything, the likelihood of finding something drops significantly after that. But if you find an abnormality earlier on, then, you know, I would recommend monitoring for at least 24 hours from that point. And does that answer your question? So basically at least 24 hours of monitoring, and then beyond that point, it really depends on what your EEG is showing. If it's generalized slowing, or if it is periodic discharges that are not increasing in frequency, that are not you know, increasing in prevalence, it's reasonable to discontinue. But of course, if you find seizures, if you're finding periodic discharges that are increasing in frequency, increasing in prevalence, or the patient is clinically getting worse and you're considering treating or escalating treatment, then continue to monitor them longer than that.
So Elizabeth, are there technical issues that limit how long you can do it?
Well, so I was interested when I was talking with our EEG technologists, in particular about ventilator desynchrony and artifact from ventilator desynchrony. And I was interested to ask Dr. Zaffar, because our technologist said that they really didn't see a lot of issue with that. And, you know, I think it's because the teams were aggressively treating this. But I wondered what your experience was with artifact of that nature, if it was a big problem.
Yeah, I mean, I think that for most of our patients, when they end up getting monitored, is when they're sort of beyond that point of requiring heavy sedatives and paralytics. You know, the most common indication is we've weaned off paralytics, we've weaned off sedation, but they're, you know, just not waking up. And you know, they still are, many of them still are on the ventilator, and even though we see some ventilator artifact, it hasn't really impacted our ability to interpret or read the EEG that much.
Yeah, and just to add, in terms of logistics, of course, we just try to coordinate if there are going to be any trips to try to minimize the unhooking and rehooking up. So that coordination is important.
Let me ask you a question about therapeutics. I mean, any change in the AED regimen, or would you recommend starting one particular drug over another, keeping in mind that many of these patients have concomitant liver and hepatic disease?
Yeah, I mean, I think that's the challenge, that with any AED, even anesthetics, but even AEDs that we choose, you know, more and more levetiracetam or Keppra is becoming, you know, the AED of choice that we often use in the critical care setting. But then our COVID-19 patients, you know, we know that a lot of them, especially the sicker ones, do get a severe acute kidney injury, often requiring dialysis. But even in that context, when we do choose treatment or anti-seizure medication, we often do start with drugs like levetiracetam, or sort of the more routine first-line agents. I think knowing the cardiac instability and the risk for myocarditis and other cardiac abnormalities, fosphenytoin or lacosamide may not be, you know, my first drug of choice, just given the existing hemodynamic instability these patients have. So often it is, even if they have acute kidney injury and are on dialysis, often our go-to drug, if we are starting an anti-seizure drug, is levetiracetam, and we would renally dose it.
Excellent.
Can I ask a separate question? So, because you have so you have some experience with Ceribell and these limited array EEGs. How are you using those in the setting of COVID, or even outside the setting of COVID? Are you using them as a substitute for EEG, as a bridge to a bigger EEG? What sort of things are you doing?
Yeah, so we typically, what we use them for is, and the way our setup is, we don't have, 24/7 tech coverage in our hospital. And so especially when there's no in-house tech, or we just can't get a tech and we're very concerned, we will use Ceribell or the rapid application EEG. And if it, clearly if it shows that the patient has seizures or concerning pathologic findings, we will try and, convert that to a full EEG as soon as we have the availability to set up the full scalp montage. But if the Ceribell or the rapid application system actually just shows us generalized slowing, and we've managed to capture that for several hours, we often take that as sufficient data and don't convert that patient into a full montage EEG. So we do use it in that context to decide whether or not this patient needs a subsequent EEG or not.
All right. Well, do you have any burning questions, Javier?
So one very last question is, Dr. Flores actually asked a question of, do either of you recommend using EEG on everybody who walks in the door with COVID? Should we be testing everybody who comes into the intensive care unit just to test them? That should wrap up.
I would say no. I think that we have to be we have to be pragmatic about it. There are health, risks associated with it. There's health costs associated, there's a lot that goes in. But I do think that we are still underusing it. I think there are patients, if they have sort of the constellation of encephalopathy, history of brain injury, or an acute structural lesion, then we should be considering EEG monitoring in these patients. But I wouldn't use it for anyone or everyone that walks in. That's my take.
All right.
If you have.
Yeah, I think, there are definitely staff and equipment limitations. I think definitely from a research perspective, there's certainly so much more to be gained, but I'm definitely with the pragmatic approach.
Well, we'd like to thank you both. You gave excellent presentations and a great review with the questions and answers. We'd like to thank both of our sponsors, Ceribell and Corticare. Any information that you would like, any further information, you can certainly go to the Ceribell website, and the Corticare website is here as well for continuous EEG solutions. We thank you both for their support for this webcast. And once again, I would like to thank both our speakers. Javier, thank you for joining me today, as well as our participants. I hope that we've answered your questions adequately. I know that the presentations were wonderful. I learned quite a bit, and I'm hoping that you all did as well. Thank you kindly for your support and for being here today. And stay safe, everyone. You know that one last talk is coming up. What's next? I'm sorry, preparing for the second wave. I've actually signed up for that one because that's something I think we're all particularly interested in. As you know, SCCM has a series of these webcasts. As I mentioned, this was the first in conjunction with the Neurocritical Care Society, and this will be the next webcast. COVID-19, what's next on the horizon? And for more information about this webcast, you can go to either the SCCM website or the Neurocritical Care website. Thank you all, and stay safe.
Thank you.
Thank you.